At Peace Health Medical Group, our experience with telehealth has been exciting, and I would say very hopeful for the future. It is a way of providing mental health and psychiatric services that we started with a little bit, and we're moderately into it, and we have plans to do a whole bunch more of it. It is a very good way to provide services both near and far. People sometimes think, oh, telehealth, telemental health services must be only to distant, underserved places, and that's absolutely true. However, we're using that technology even within, our own city, between hospitals. However, having said that, the psychiatric services, both adult, child adolescent, inpatient, and outpatient, are services that we certainly are providing to, one would say, more distant or even rural parts of our pretty vast network catchment area, where there is a real dearth, a very lack of psychiatric services and mental health services, where families and primary care providers and hospitals either don't have a psychiatrist or have extremely limited psychiatric and mental health services available.
Telehealth, how we're using that to support our services is the crisis services in the emergency room. We provide evaluations, mental health evaluations to patients in crisis via the telehealth. And then we also provide psychiatric consult for patients on the medical floor in our rural hospital in Florence, and some outpatient telepsychiatry as well to Florence and Cottage Grove.
In order for us to provide more mental health service to more people, one of the most important ways to do that is to access patients in primary care, where they are often coming for other health needs and where they either don't have a psychiatrist or they might be less likely to go to a dedicated mental health or behavioral health clinic, but they will go to their primary care office. And so if we can provide services under the umbrella or under the auspices of primary care, then we're really a step ahead in access for psychiatric and mental health services.
There were definitely reservations in the beginning about starting telehealth and doing the telecrisis. We have some very skilled and seasoned mental health clinicians who were very used to being able to be in that room with their patient, and so I can laugh about it now, we all can, but initially what they would say is, I can't smell that patient, I can't feel that patient, and that was their worry before they really even tried it, right? And then we had some really young, new in the field clinicians who were technically savvy and just said, oh, this is exciting, wow, this is really new. And so so they actually ushered some of the old timers along. The clinicians really provide the same service and with the same method face-to-face as they do through telehealth. We coordinate with a physician. We see a patient at the order of the physician, right? You have to have a physician's order. So in face-to-face, you're actually talking to the physician. You're standing next to him or her, getting information about the patient, and then you step in and see that patient. When you're done, you go back to the physician and you explain what you think is going on and what recommendations you have, and together you work that out. And that's usually the end of the encounter. In telehealth, with the telecrisis, it's really the same. In practice, what happens is that you are calling the physician on the phone because they're in Florence, an hour and a half away. You're getting the read on the patient, what they would like. Then rather than you stepping in, the nurse steps in and explains to the patient, this is who this person is, and then you get on the monitor and you talk and introduce yourself and build rapport the same way you would if you were in the room physically. Do the evaluation, and then you sign off and let them know that you'll be speaking with their physician, and then most times they will remove the equipment, and then you call that physician and discuss, consult and make recommendations. If that person has an outpatient provider, a physician, a therapist in the community, the same as if we saw them face to face, we would send the evaluation on to them so that they knew that their patient was in the emergency room. So, I think that for a clinician, it's mostly getting used to the rhythm of now I'm being seen and I'm building rapport in a different way, and now I'm signing off. But by and large, it's the same process.
Compared to face-to-face psychiatric work and evaluations and treatment, psychiatric work via telepsychiatry or telemental health has way fewer, I would say, way more similarities than differences. We find that actually for adults, and since I'm a child and adolescent psychiatrist, for children and teenagers as well, the modality is generally very well accepted. And contrary to what some people might think, where the physical presence of the patient may be thought to be, essential, I would say that's certainly ideal, and most of us are trained that the physical presence is very important, and that's true. However, the quality and the technology of the reproduction and the audio and the visual is actually remarkable. And I would say that as I sit and I look, at the visual, and I have control over how I can zoom in, and the audio quality is quite good, the reproduction is excellent. I can do, I would say, almost everything that one would do in a face-to-face visit.
The keys to using this approach successfully is to have buy-in from the staff, I think, most importantly, right? Because it's still new to some of them, and we've taken to the place of really asking during interview, are you familiar with telemedicine? We use that here, and we do this with psychiatry. Dr. Brasted could tell you when we interview psychiatrists and nurse practitioners, we also ask, we inquire, because we are moving in that direction. We've been doing this and we want to grow. So I think that's key. And when you start off in a brand new, you're gonna you can expect some skepticism, and to be open to that, and just have people play around with it and get comfortable with it.
I actually have not had a patient or a family yet say, no, we don't like this, we can't stand it, or we really do need to see the doctor in person. Actually, many more have said, no, they're fine with it. Since mental health services are in such short supply in so many parts of our catchment area, without mental health and telehealth services, primary care providers, families, patients, children, adults are really bereft of psychiatric services. They're depending on their primary care provider to supply that, and many of them can. Many of them do a great job, and actually I find that in the consultative realm that a lot of times a primary care provider needs sort of support and encouragement rather than, oh boy, you're doing the wrong thing, or gee, you sure didn't know anything about that. I actually rarely find that. However, their skills really do vary, and it's like any medical or surgical specialty. The specialist, the trained person's, viewpoint and input is just makes a world of difference. Without access to those services, a lot of patients and families languish.
The scheduling is done centrally, so the patients are scheduled for me. So there's a dedicated room that has the hardware equipment, a camera and a TV screen, chair, a couple chairs and a couch. And what generally happens is I will let the team know that I'm available through a text message or using the electronic medical record. and they'll bring in the child and the family with a clinician, either a QMHA or a QMHP, who's there throughout the appointment, and that always happens. I think that's important for safety as well as for continuity of care and good coordination. And then I'll turn on my video, and their video is always on, so I just turn my video on and introduce myself and proceed from there. And at the end of the appointment, they would leave the room just like any other appointment, and I'd do my dictation, I'd dictate my notes, and then I'd be ready for the next patient. What is most valuable about telemedicine and telepsychiatry, and maybe even telechild psychiatry specifically, is that that service is such a scarce resource that the ability to extend the provider to various parts of the state, rural populations, and clinics that would never have a psychiatrist on site, or very rarely, is really the best benefit of the modality. I know for a fact that no psychiatrists or psychologists even have a residence in Harding County. So the ability for me to enter in there virtually, 2 or 3 times a month, I think provides a lot of access to the membership. First, I'd say do it. It's a very rewarding experience. It is very feasible. I think one of the perks is that you can do it from your own home office. So it's actually convenient for me or for the provider to not have to travel at all, yet cover a great deal of distance. I would suggest that if at all possible, you arrange a situation where you can go out and have site visits, at least a couple times a year. Again, the purpose would be to really get to know the treatment team and staff that you're working with and form those relationships. I think that's pretty critical, because most of what we do as psychiatrists, and especially child psychiatrists, is team-based care in the specialty behavioral setting or in the primary care setting. And I think getting those relationships developed is really critical to the overall treatment process. Of course, the relationship with the patient and the family as well, so that they can see you in person. I went there last Friday for a full day, and the people just kind of lit up and were like, "I can't believe you're here in person. It's so great to see you. This is my first time to meet you." And and this is maybe somebody that I've been seeing for 3 or 4 months. So I think that's critical. I know some people don't do that. Of course, the national providers of telemedicine that see people across state lines generally don't do that. So I would strongly encourage Oregon psychiatrists who have an interest in this to pursue it, and then try to carve out some time to have site visits as well. The systems and the costs needed to develop some basic but good infrastructure for telemedicine is quite reasonable. Even a couple of laptop computers with a secure software program is enough to do an adequate job. I would encourage them to review, various websites. There's state and national telemedicine websites and practice guidelines, and I think it's important to follow those and review those if they're interested in it. But there's just such little real barrier to developing the system that for me, I think it's almost a no-brainer to offer that, especially if you're in a setting that doesn't have access to a psychiatrist in the community.